This is Shoshana Zass from CIMH, and welcome to the first in the Small County Wellness Centers webinar series. In a few minutes, Dr. Ann MacRae is going to be presenting on collecting, organizing, and reporting outcome data in wellness centers. But first, a couple of things. You are all currently muted, and will be pausing on a regular basis to ask for questions. So if you'd like to ask a question, you can do so by either typing it into the question box that you'll see on your control panel, or by clicking the hand icon next to your name, which will alert us to take you off mute so that you can ask your question. You should have all received materials for today's webinar via email on either Monday or this morning, but if you didn't receive them, let me know. I received several failure notices because the file was too large, so we might have to come up with another way to send them. And this webinar will be recorded and posted on the CIMH website soon. You'll receive a link to the recording when it's available. So thank you all, and now I'd like to introduce Dr. Ann MacRae.
Hello everyone, I'm excited to be back. I think this is the third series that I've done, and I love doing them and love interacting with you, so please don't be shy to ask questions at any time. For those of you who have been attending these webinars with me regularly over the years, you may remember that this particular topic of outcomes was covered last March in a session called Measuring Success and Documenting Outcomes, which is also archived. You could go back to it. I got a lot of feedback then and since then requesting that that topic be repeated. I guess it's a big one on everyone's mind lately, so I'm happy to do it. This year's webinar, I saved some of the same slides and will repeat some of the same messages, but it's also been updated with new examples and some new material. So if you were at the one in March, some of it will be a refresher, but some of it will be new material as well. Okay. Notice on this front slide that I have my email on there. It's my San Jose State email, but I get it everywhere I go. So don't hesitate at any time to send me an email about questions, or if we don't get to something today, or if you want other resources, please feel free. Okay. Where can I? Uh-oh. Oh. My machine is being very weird. Hang on with me a minute. I don't know why it doesn't want to click to the next slide. Okay, the next slide is objectives. And these are for you to review at will. We don't have to say a lot about them. I always have objectives with what I'm doing because it helps me organize what I want to say. More importantly, they're a way for you to hold me accountable that I cover what I'm going to do. And again, this particular one presentation covers outcomes for wellness centers, but specifically looking at how do we collect and organize and report these outcomes. Okay, I think what I did here, I'm sorry for the scrolling funny, I think, I don't know why, my, let's see. If this is ever out of whack with your screen, please raise your hand. For some reason, it's not letting me click slide to slide. I have to scroll through it. So hopefully that's not too disconcerting. So the third slide is, why are outcomes important? As you can see here, outcomes really do serve a lot of purposes. I think most people now have gotten the message that they are important, but I still feel some resistance. Certainly, let's face it, people who work in wellness centers do it because they enjoy working with people, not data. But I do want to emphasize that your survival as an agency depends on documenting and communicating your successes with clear and accurate outcomes. Every agency and every staff is at a different level of comfort with this, so don't be shy about asking any questions. I guess the overall message on all of this is if there's one thing I really want you to get from this session is buying into the necessity and critical importance of doing outcomes. So I think those are pretty self-explanatory, and they'll become more so as we go through Okay. So, challenges with documenting wellness and recovery outcomes. I see a couple of important issues with these challenges that every agency has to face. First, collecting and analyzing the data to document outcomes takes time and skill. So the very first thing that an agency has to prioritize is the resources to get this done. Sometimes that requires a heart-to-heart discussion with your administrators and staff to make sure that the time is put aside and any training that's needed is provided. And that sometimes requires some negotiation. This is not something that a lot of people will come in here into a wellness center job understanding. For those of you who, particularly for those of you who work in wellness centers that are completely or primarily consumer run, it seems the right time and place to consider partnering with someone, a clinician or a business professional who has this background. Now, of course, in some cases, someone who happens to have a lived experience of mental illness does have this background, and that's great. But not always. I have worked with a lot of people who this is entirely new to them and a pretty steep learning curve. I've mentioned this in previous webinars, but I think it bears repeating. Although philosophically, I completely support consumer-run agencies, I do think that there are so many different skills required for success that partnerships and collaboration with professionals is a great model, with one caveat: partner with professionals who truly understand recovery and collaboration. I understand that nobody wants someone to come in and kind of take over. But there are a number, more and more so, I believe, mental health professionals who truly do understand recovery, who truly do understand working collaboratively with peers. But they may have some unique, specific expertise that you don't have. So I would encourage people to take advantage of partnerships like that. I added one challenge to this slide since the earlier presentation, and that is a lack of structured scheduled programming. Look at the previous bullet point to that. It states that you need to have a starting and an ending point to know what your baseline is in order to determine outcomes. However, from my conversations with many of you and observations with wellness centers, there's often a lot of unscheduled open time with minimal structured programming or programming that is ongoing with people joining at any time. While this flexibility may be enjoyed and even needed by participants, it really does make collecting meaningful outcomes a serious challenge. So I'm not saying your whole program has to be super structured, but if you don't have some programs like this now, I would urge you to consider adding some groups that have a definite starting and ending point, because they really are your best bet for collecting meaningful outcomes. The final challenge listed on this slide is the limited amount of tools or instruments that can be used by and for people in wellness centers. I want to qualify that statement a bit. There are lots of assessment tools that have been designed in the last 5 or 10 years focusing on recovery. However, they really were primarily designed by researchers to be used by mental health professionals in traditional treatment centers. And I'm thrilled that we're finally getting to the point of exploring the concept of recovery and treatment. For this presentation, I want to focus on methods that can be used primarily by and for consumers, and there are even quite a lot of those now. We're going to look at both some published ones and what I call self-designed ones, some models for you to create your own. I'm going to pause now for questions or comments. Did I miss anything, or what are your biggest challenges in documenting outcomes? Does this cover it? No comments?
Nothing yet.
Okay. You know, once in a while, I don't know if any of you have ever conducted webinars, but sometimes you feel like you're just talking to space. So every once in a while, if people don't jump on the bandwagon and contribute, just type in something to say hello or thank you or I'm here, or just so it helps me feel better. Okay, we'll move on. It can be a little disconcerting for those of us who have taught, you know, in big classrooms with lots of people and lots of interaction. The next one is called Measures of Individual Recovery, and there's a great quote here from an article from Brown that I've always really liked. If we are to embrace outcome measures, let's measure the things that are relevant to the new culture. And this article was particularly about wellness and recovery. There was another study by Campbell, Ord, and a bunch of other people, the source is listed at the bottom, that did a big research study to identify what are the things that are most important to people in their individual recovery. So as you can see, so in other words, the domains that are mentioned in this slide are very consistent with the true meaning of recovery as identified by people in recovery. I think that's an important point. There are so many areas because health, wellness, and recovery, like human beings, are very complex, and all aspects are interrelated. This actually means that doing any kind of research or data collection in a true wellness model is actually more difficult than a lot of the scientific research that goes on in medicine or other branches of science, where they look at one thing at a time and everything is broken down. In wellness, everything is related. So how on earth do you collect information on all of this? Well, the first thing to keep in mind is that it is the individual in recovery who determines which of these areas are the ones they want to make goals about. And once that's done, some of the information, such as the amount of services are used and the demographics, are actually very easy to document if you keep good records. But that's only kind of the tip of the iceberg. Also, most wellness centers who collect outcomes at all try to do it on a program or group or agency-wide basis. It does make sense in terms of time management. But such outcomes are still going to be based on a list such as this. What are you going to be asking about? And again, I'm going to be giving examples from both published and self-designed instruments. Okay, ready to move on? No questions? Oops, I missed one. This is just a statement. Published instruments versus self-designed instruments. Published instruments usually are developed by trained researchers. They have the advantage of being tried and tested. If you've never tried to develop a survey or anything like that, it's really much easier to do it from somebody else's work. However, the drawback of them is that they may be too broad to meet specific needs of your agency and also the individual people you work with. Not to mention, I didn't put this on the slide, but not to mention most of the published instruments are really long, and therefore the participants in your center may not be willing or able to complete them without help, which is of course time consuming. So if you are using such instruments with the idea you're going to save time, that may not actually turn out to be true. If you're using such instruments because they really do capture the information you capture and they're well designed, that's great. But what I would suggest is as you're looking at any published instruments, keep in mind what is it you're trying to collect information for, and is that particular tool going to help you? Okay, I want to give you a review of a sample of one published instrument. The file that Shoshana was talking about that a lot of people had trouble getting, so maybe not all of you got it, was a big PDF file. It's a 254-page booklet, which is why you may have had trouble downloading it. It's called Measuring the Promise, a Compendium of Recovery Measures, Volume 2. This booklet is free of charge. It's chock full of published instruments, and I would urge you all to read this through and see which of them would work for your setting. Also, even after this presentation, if there are other published instruments that you use and you have good experiences with them, I'd love to hear about it. If we continue to have problems with getting this booklet to some people because of the system, it's probably your computer system will not allow such a large file. We can try a few different things to get it to you, but if you continue to have problems, I'm pretty sure that I got this from the SAMHSA website. So all you have to do is write to me and I'll find you the link, and then you can download it directly from them, and it may be a little easier. But it's a great resource. I strongly urge you to look through it. But I'm going to highlight one assessment in this booklet because it's one that focuses on what I call recovery-oriented environments. For those of you who know me or have done webinars with me before, I'm a big interest of mine is how the environment supports wellness. This particular instrument is called the Recovery Self-Assessment. It's very useful because it actually looks at wellness recovery environment from 4 different perspectives. There's 4 different versions of this. There's a person in recovery version, a familiar significant other advocate version, a provider version, and a CEO agency director version. You could get a very thorough assessment of your entire center using all of these versions and then comparing the results. However, depending on your needs, you can also use any one of these tools independently. It's not required that you use all 4 together. And probably most people will just use the person in recovery version because that's usually what we're most interested in getting feedback and data on, is how they're doing. However, if you do more of them, if you're getting different perspectives, I see this as a great way to really get a very objective overview of where you're at. And if you're finding that there's dramatically different answers between the different stakeholders, that tells you something right off the bat. You have a communication problem. You are not all on the same page in where you're going. And that, from an organizational perspective, can really hold you up. And sometimes you don't know that until you go through a process like this. You may think, oh, they don't understand what we do, or vice versa. But this is a way of really nailing down where you're on a different page. So that's very helpful. This is also a good time to point out that when you're collecting data, we sometimes fall into the trap of thinking that all outcomes are final and they all need to look great. In reality, it is absolutely essential that you are honest with your outcomes, and even if the results look poor, they can be helpful. If you can demonstrate that a concerted effort is being made to identify what needs are not being met and developing a plan to correct shortcomings and improve outcomes, that goes a long way with supporters, even surprisingly funding sources. Funding sources often require kind of intermittent reports. And although you can highlight, and we'll talk about this later, you certainly want to highlight the positive. It's important that all data be honestly reported. And again, even the things that aren't going so well, if you're coming up with a plan for correcting it, and you have explanations for it, it goes a long way, and it really does help. Okay. What I'd like to do now, I'm actually going to go out of this for a minute, if it'll let me. Why won't it let me? Oh my goodness. Okay, there you go, sorry. To show you what this instrument looks like, for those of you who haven't either gotten the booklet or if you haven't had a chance to look at it, I'm going to point out the one that I'm talking about. And it's at the very end of this very, very long booklet. Let me just give you, let's look at the person in recovery version. As you can see, can you all see this, I hope? It's on a very simple 5-point Likert scale. Usually there's 10-point scales if you're doing big-time research are more accurate, but 5-point scales are usually more user-friendly. And for small counties where you're not going to be collecting massive amounts of data, I would suggest going with this. They're basically a list of statements. Staff focuses on helping me build a connection in my neighborhood and community. 1, strongly disagree. 5, strongly agree. And they're all statements like that to give you a feel for how the entire process is going. Okay, and this particular one is 36 questions. So it's not too labor intensive. Again, there are a lot of clients that I work with, maybe participants in your wellness center, who may have trouble with literacy, attention span, any number of reasons that may require someone to help them with this. Unfortunately, that may also change their answers. So you need to be very sensitive to that. Would you like help with me reading it to you, but I won't look at your answers, or something like that. There's some strategies that you may need to use to make sure that people feel safe in giving honest answers, because that is really what you're looking for. Okay. So, and as I said, there's 4 different versions of this, and it's all at the very end of this booklet that I sent out. Are there any questions about this particular instrument, or could you see yourself using it at the center that you work at? Do you use something like that? Anyone going to help me here?
There's a comment from Linda.
Great.
Clients that I've worked on RAP have found this process very helpful in identifying their goals and finding coping skills when confronted with obstacles.
Fabulous. It's very funny that you brought up RAP, because I'm going to talk about that in a little bit. Great program, but how to document the outcomes can be a little tricky. But yes, the first part of it, where they can actually get involved in establishing their own goals, is critical. And RAP is a great program to do that. That's actually, I'm also glad you brought that up for another reason. You may remember earlier I said that a lot of wellness centers just have a lot of unstructured time. And I suggested adding some programming with a definite beginning and end. And if people aren't familiar with doing those kind of programs, the first one I would suggest is getting one of your staff trained in as a RAP facilitator and offering that. I think it is really, it's a well-designed curriculum. There is clearly a beginning and an end point. It's perfect for that. Okay. Any other questions or comments? Oh, now my little thingy's working. Cool. Okay, so that's a sample of an already published instrument, and as I said, the booklet that I sent, and hopefully you got, has lots more. I will go through them and see which ones will fit your needs the best. Okay, now I want to give you, talk about a self-design tool. What do I mean by that? In a few minutes, I'm going to show you some scales that I designed for such an upcoming group that we're doing. But first, I want to explain a little bit about the way I design them. My favorite way of designing outcome scales is to use what's known as a visual analog scale, or a VAS. And I'm going to give you an example of that. What these scales are, it's a little different than the Likert scale I just showed you. It is a response scale like that, but it can be individually tailored and self-designed for specific questionnaires. And when the person is responding to a VAS item, they respond to their level of agreement by indicating a position along a continuous line. There is solid research evidence showing that a visual analog scale has superior metrical qualities than other instruments. And I may have lost you right then. Let me back up a minute. I could talk a lot more about this, and there's a lot of reasons why this tool is very good, but I couldn't do it without teaching you a whole class on research, and I don't think you want that. But a point I want to highlight. One of the interesting features that makes VAS instruments so strong is that they are visual. In other words, it's important that you actually show people the scale, preferably with pictures. You're probably most familiar with these kind of scales if you've ever seen any pain scales. Usually there's a happy face on one end and a grimace on the other. I have to say that such scales are often very misused by doctors and therapists who simply ask. You may be in a doctor's office and they say, okay, on a scale of 1 to 10, how bad's your pain? They may think they're saving time just verbally doing that, but the validity of the answers has shown in research to be far weaker than if they just took the time to show someone a scale. I know that sounds weird, but this has been pretty well documented in the research. So if you're designing your own scale for a specific purpose, I suggest the following steps. You provide written instructions where people clearly understand why this information is being collected. You provide examples with not only the numbers, I like actually adding pictures. I mean, it can be something as simple as a happy face. I'll show you a sample in a minute. Very important that you determine the starting date and the ending date of the measurement. This gets back to my earlier point about there's a problem when you run a kind of ongoing group where people can drop in whenever they want. These kind of groups are run more on what's called a psychoeducational model, that there's specific objectives that you're trying to meet. So you have to know where people are starting out in order to determine where they end up. And you can't be continually repeating the same information. So, think of it more like a classroom. You can't just like float in and out of a history class and expect, to pass the final exam because you only got like 1600s and 1900s and you missed the 1800s or whatever. And it's important to get people on board and kind of committed to staying with the whole program. This is, again, why I like the RAP program so much. It's very clear that you're supposed to attend and you're supposed to go to all the sessions, and the sessions start here and the sessions end there. You also need to be very specific about what is being measured as it relates to the program. I like, personally, to look at knowledge change as well as practice change. And they're very, very different outcomes. In other words, someone may learn a lot about, say, in this particular group, I'm going to show you the food, mood, and move group. We're doing exercise and nutrition, basically, and how it affects one's mental health. They may know a lot, but they may not do anything about it. So those are two different things. Some people may actually have some good practices and they don't really know the background why, but just they grew up that way and that's the way it is. I also see this as different from a lot of the instruments, the published instruments that I see are really measuring satisfaction, their perception of how happy are you with the service offered. That is, again, different from either knowledge or practice. So once again, I'm going to go out of this for a minute to show you some scales. Now, I did not send this ahead of time because you wouldn't have had any idea what it was for. And again, it's just an example of what I designed for a group we're going to do. You may want to do something very different. If anyone wants this as a template, to get you started on designing your own, I'm happy to send it to you. Just email me. So I follow the steps that I said. I explained to people what it's all about, that we're asking, in this case, I'm having them do 4 different scales. Their knowledge and practice of nutrition and their knowledge and practice of movement, exercise, because that's what we were covering in the group. Lots of times you may only have 2, or maybe you're only interested in knowledge, or maybe you're only interested in practice. There's no rules in this. You design it the way you want. And if any of you ever want any help with this, if you want to give it a try and do a draft of one and email it to me, I'd be happy to look at it for you. So the information, I explained what the 4 scales are. Towards the end of the group, I'm telling them ahead of time, 4 to 6 months, we're going to ask you to repeat these scales because it will show you the progress you have made. And so I think your best bet of getting people to cooperate with you on collecting data is letting them know what's in it for them. And it's amazing when I have added these to groups how much more satisfaction, confidence, build self-esteem. It's like, wow, I really did learn a lot. I really am doing better. And I think so. Outcomes isn't just an administrative kind of thing for funding or anything. I actually do think when you have this built into services and it's done in a very kind of user-friendly way, it actually helps promote recovery in and of itself. So what I did on this scale, like knowledge of nutrition, I put in a little picture of junk food, 1 meaning I don't know anything about nutrition and its effects, 10 meaning I've studied nutrition and know a lot about it, but the point is they circle 1 number anywhere along there. The 1 and the 10, I give statements just to describe the difference. Same thing with practice, and notice the difference. The knowledge is about what they know, and lots of people know lots of things. That doesn't mean they do anything with them. Practice is, well, maybe this is my bias as an occupational therapist, but I'm always looking at Well, what are you doing with it? So talk about practice. No, my diet is actually pretty bad. I know that I'm not supposed to eat so much sugar, but I do it anyway. Versus the other end of the chart is 10. I consistently eat a balanced diet with healthy choices. Most of us are going to be not a 1 or a 10. We're going to be somewhere in between. Exercise, same thing. I have a little spud potato on the couch, and then a little exercise guru at the other picture. These are just clip art things I get free from the web, but you can put in photographs, you can put in whatever you want, or you can self-design them. But I actually do think it helps people, and I've worked with a lot of different people with a lot of different capabilities, and uniformly, it seems to help them understand what these scales mean. So the exercise scale, I don't know anything about exercise and its effect. I've studied exercise and know a lot about movement effects. Again, there's a difference between knowledge and practice. You can know a lot and not do anything. So on the practice scale, I don't do any exercise at all, and I avoid movements and daily chores. 10, I consistently exercise at least 30 minutes a day. This is a one-page thing. One of, as I mentioned, and you get a lot of data, a lot of data. As I mentioned earlier, one of my big problems with a lot of the published kinds of tools is how long they are. So this is pretty easy, and I often actually do it. Another question that always comes up is, oh, we leave these surveys around the center and no one ever fills them out. Do it as part of a group. You know, when I'm starting this group, we're actually going to start this group in January. I always, by the way, create the outcome measures before I do whatever the intervention or group or program is. That keeps me honest as to what I'm supposed to be providing you. So on the very first day, say, let's get a baseline. Let's see where you're at now. This does a few things. It helps me come up with outcomes at the end of the program, but it also, I look at them right away because I may change how I'm going to run the program depending on where the group is at. If it looks like most people in the group really do actually have a lot of knowledge and they just need some strategies on how to put it into practice, I'll put more focus on that. But if it looks like there's some big knowledge deficit, then I'm going to have to spend some time on it. Okay? So, what do people think about self-designing instruments? Are there any questions about that? Could you see yourself designing one? Would you need some help designing one? Can you think of a program you offer now that this something like that might work for? I'd really like to hear from you folks. Does it terrify you to think of doing that?
Nothing yet, but Jim Isherwood was kind enough to send the link to the compendium, the very large document.
Perfect.
So I'm going to send that out in the chat box to the entire audience.
Jim, I appreciate it. You saved me a little legwork. Thank you very much.
And now there's a comment from Shauna. We can see this as a conversation starter in our groups.
I'm sorry, could you repeat that, Shoshana? I didn't.
We can see this as a good conversation starter in our groups too.
Wow. Okay, that I hadn't even thought of that, but that is actually a very good way to do it. Even if you're not ready to do it in a formal way, in a scale, although I do hope you get to that point. I think starting, if people in your center are completely unused to the idea of that we may be collecting outcomes, having a conversation with them about how it helps their own recovery, I think is a great idea. Thank you. Excuse me. Anyone else? Okay, how are we doing on time? What time do we have to?
11:30.
Okay, we're fine. We're fine. All right. So, organizing and reporting. as I mentioned before, some data can be reported with very simple tallies and statistics with or without accompanying narratives, depending on the purpose. And you probably all do this. How many people attend, for how long, uh, what kind of programs are being offered. That's just simple numbers. Although I really would suggest that your staff who collect this get used to using something like an Excel spreadsheet so it's accurately calculated. Narratives, meaning like a written explanation, can be very time consuming, but they provide an opportunity to explain the data, what these numbers mean, to interpret them. This is especially important for low population areas, which many of the small counties that you're from, this has always been an issue. The numbers really in and of themselves don't mean much. So you had 8 people come today. If someone from Los Angeles is reviewing that, they're going to go, what? But if you can explain that, that's actually a pretty good number because, no one has transportation and, there's only, 1,000 people in this town or whatever the situation is. So it gives you a chance to explain that. It also gives you a chance to explain changes, and that's actually, even from major researchers' perspective, that's the more important number. So in other words, if you had 8 people attend daily last year as an average, and then this year it's up to 16, you have increased that 100%. It's the change that's actually more important than the numbers. I hope that makes sense. But so there are ways to present data that actually capture more what the situation is in your particular environment. Summaries, it's very important when you write summaries, and most people do require writing summaries, even if you're giving numbers. It must reflect the total data. I mentioned earlier that we all want to put our best foot forward, and there are ways to do that by highlighting the positive, but you can't ignore negative data. The summaries must reflect your total collection of information. I'm going to give you an example from a RAP summary. I'm going to show you that here in a minute. Our peer specialists here at our center run the RAP program. They are certified to do so. And for those of you who aren't familiar with that, it's the Wellness Recovery Action Plan. It's a really great program. And the peer specialists who did it the last session used the provided program survey to collect outcome data. She came to me, I don't know if she's online here, but she can chime in if she wants to. She came to me with pages and pages and pages, I don't remember, 12, 16 pages of results, and in a near panic. And she said, what do I do with this? And, well, all due respect to Mary Ellen Copeland, who designed the RAP program, and it's an extremely important, critical program. The survey instrument that accompanies the RAP curricula is one that I would never use. So I'm going to show you what I ended up doing with the reams of paper my colleague handed to me. Once again, I'm going to go out of this. And hopefully it's not too disconcerting to you for me to be going back and forth between programs, but on some of these other things, there's just too much information to put on a slide. And these are just samples. Again, I didn't send this to you ahead of time because and it is confidential, but it's also anonymous. So what I ended up doing with all the stuff that was handed to me is coming up with a one-page summary. That in and of itself, forget the content, that's important. You need to keep in mind that when you're writing up this stuff, somebody has to read it. And they are going to be very appreciative if you're concise. Now, you want to hit all the main points, and you want to make sure that you are honest about the data, but there are ways to do that to keep it very, very concise. It is more readable. You're more likely to get someone to positively read it and understand it. So try and work on conciseness as much as possible. Okay, so what I did, the first 3 questions of the summary that's attached to the RAP program is pretty good, but I put it into a chart. Well, before that, let me back up a minute. I do give a very brief introduction. This was a group that was held in last summer. There were 16 people, 2 of them clinicians. This instrument was designed by Mary Ellen Copeland, and 9 people completed the survey with the following results. Okay, so the first 3 questions are pretty straightforward. I always feel using direct quotes is the most powerful way to do it. So I basically just culled through all the stuff for the answers for these 3 questions and listed the quotes. So this is the voice of the consumer. That part was great. Questions 4 through 12 pose various statements regarding the quality of the course offerings and ask members to rate them on a 3-point scale. False, somewhat, true, true. Since the responses were limited, a statistical analysis was not conducted. In other words, you just have 9 people. Those numbers, you could do any fancy statistical thing to them at all, and it will be absolutely meaningless. So instead of even, listing a bunch of information, or 2 participants said false, 3 participants said true, whatever, just do the summary. The general trend indicated that overall the participants believe the group was well designed. So I answered the question. I'm honest to all the data, but I didn't write everything out. Questions 13 through 18 posed questions that were specific to the group leadership, as well as general questions regarding the value of recovery education. In this particular situation, and I had to be honest about this, due to the length of the survey, the majority of people did not complete those questions. So I added my own recommendation. It's recommended in the future offerings of RAP a redesigned survey form be used or additional time be granted to complete the current form. Okay? Short, simple, sweet, but honest and complete. That's what you're trying to get for in these summaries, no matter what kind of assessment you're using. Okay? Questions?
There are a couple of questions going back to the survey instrument.
Okay, great.
One person
Which one?
Like,
the one I designed?
Yes.
Okay.
One person would like a template for the food and exercise. And then there's
the best way to do that, so I remember, is to email me. My email's on the first page. And please feel free, email me. I'll send it to you right away.
And the second question is, was there an outcome measure for mood?
That's a very good question. There wasn't, because the whole point of this particular group, let me go back to it again. I could have done that. You're right. But what the research shows and what we would say in every single session we do is that nutrition and exercise have an effect on mood. We could have certainly added that scale, but I think for myself, I was very interested in applying the practice part. I'm going to make an assumption that if the norm was going along with the research, if they actually improved, and maybe that would be a great follow-up scale to do. Maybe I'll do this. Thank you. If your diet improved and if your exercise improved, did your mood improve? That's another whole kind of thing. But you certainly could do a beginning and an end on how's your overall mood right now. I didn't do that, but it could be included, for sure. I would probably just do that as one scale. I wouldn't divide it down like this, like knowledge and practice, because it doesn't quite fit in the same way. Just a one very simple scale, on a scale of 1 to 10, how would you rate your overall mood, from being I'm completely hopeless to I'm very stable and optimistic, or something like that. It's a good idea. I could do that, and I may follow up with that. Okay? Any other comments? But it doesn't quite fit in the knowledge and practice schema that I had here. I think it would have to be kind of a separate scale. Again, the point is that there is an assumption made. it would be a great research study to see if it holds true, but there's actually a lot of research that says if your diet is really good and your exercise regime is good, your mood's going to be better. And this applies to people who have documented, diagnosed major depression or bipolar disorder, as well as everybody else. Any other questions or comments? Okay. As you look at this wrap thing, you'll see that the questions that didn't get answered mainly had to do with the group leadership. I think one of the problems with Mary Ellen Copeland's scale is that she tried to cover too much. I think sometimes it's important to separate out the teaching or the leadership versus the learning and the content. And you have to ask yourself as you're designing instruments, what is it that you really want to know? Is it important for you to know how the teaching went? If a great person has been doing the same group for a long time, they don't necessarily need this feedback on their teaching all the time. But if you as a program director, say, or someone who's involved in staffing, want to know, would you like to have another facilitator do the program? Or do you want a performance record on file for that group leader? Or does the individual group leader want the feedback on how they can improve as a group facilitator or a teacher? Then yes, you need that. But sticking it on at the end of a long evaluation is not going to give you the answers that you want. So how do you do that? I would suggest having actually two different instruments. I'm going to show you one more sample here. This doesn't directly apply to mental health. Okay, wrong file, sorry. Where am I? Let's see. But as you know, I was a professor at San Jose State for many, many years, and we had our master's students, occupational therapists in training, do presentations all the time, out in public and on campus. And as part of them learning how to run groups, we had them do what was called the teaching effectiveness evaluations. And this is the template that I designed for my students. You could do something like this for group facilitators, your staff. You can call it something else. It doesn't have to be teaching effectiveness evaluation. There's a very pretty picture of San Jose State University. You could put in a picture of your own center or your own logo. What was the topic? What was the date? What was the presenter? Again, this is a template, so that part can get changed. So this, again, is just a very simple one-page, three-point scale, but it is geared at the presenter. The qualities of the group leader, you can call it group leader, not presenter, the teacher, whoever you want to call it, but the person responsible for giving the information. Were they knowledgeable? Were they well organized? Were they well prepared? Was the material relevant? Did they manage the time well? All of these factors, of course, affect how much the person will get out of the program. But it's not so much about the content of the program or even about the changes that the individual went through because of it. It is about how it was organized and taught and how the group is led. If you need something like this, then I would suggest pulling it out separately. In other words, only ask the questions that you're going to use the answers for somewhere. I always like to have comment sections in here too. Again, for people who are new to leading groups, they really want feedback like this. But if you stick it at the end of another long evaluation, you're not going to get at it. So I suggest doing something very simple like this. Again, this is a template that I've used for my grad students. It's more geared towards professionals teaching, but you can get an idea as a template if, group leadership effectiveness evaluation or something like that. You could change that very easily. If anyone would like this as a template, all you have to do is email me. I'd be happy to provide it. So does that make sense, separating out the outcomes for the participants of the group versus feedback on the group leader? I'm going to assume that's a yes. Okay, moving on.
Yes.
No comment. Okay. Okay.
And another yes. The yeses
And
are
another.
coming in.
Okay. Thank you. I like the. Really, it does help me. I appreciate it. Okay, just real quickly, not so quickly, we do have time. I want to go over just some additional tools and methods. Right now I gave you one example of a published tool plus the booklet that I hope you got or will get the link for, and one example of a self-designed tool, and then some examples of how to write it up. There are many more additional published instruments. As I said, there's a bunch in that booklet that's, if you don't have, you're going to get. Does anyone else have favorite ones that they want to share? Or just feelings in general about the published instruments? Again, I'll repeat, if you're not comfortable designing your own, by all means use these. They're tried and true. They've been tested. They're usually well designed. The downside is they may not be specific enough for you. They may not be asking the questions you want asked for your needs, and they tend to be very long. But they are certainly worth exploring.
And
yes.
Sorry, there's a request that you go back to full screen mode.
Oh, I'm sorry. Thank you. Good catch. There we go. Is that better?
Oh, it's good.
Okay, thank you. Thank you for saying that. Client satisfaction surveys, I put that as kind of a separate category because they can either be self-designed or published. Frankly, a lot of the published ones are more client satisfaction surveys. And I, again, just want to point out the difference between collecting changes or outcomes in knowledge base, actual practice, or satisfaction. Some people feel that the satisfaction surveys, although they're used all the time, I mean, even major HMOs like Kaiser use them constantly, they don't really tell you, by some definitions, real outcomes, if anything's changed. And that's what a lot of outcomes are about. Clients may be very happy because you don't get in their way and you let them watch television all day. Is that really getting at what we're supposed to be doing on wellness services? So I personally like to separate out these three things. And they're not the same. People mix this up. Is knowledge and practice and satisfaction all the same way of saying, different ways of saying the same thing? It's not. Let me give you an example, because there's no right and wrong with these. The other thing with these kind of rating surveys is people get very sensitive about maybe I'm not doing so well, or they want to figure out what answer you want to hear. And you have to keep emphasizing there's no right and wrong answer, and everybody's going to be different. And the example that I use is usually a sports person. It's like, for example, Michael Jordan. Those of you who are, he's retired, so maybe not everyone knows him, but he was a major star in basketball. And so if I was giving a scale to Michael Jordan about his basketball playing, how satisfied do you think he would be? Probably not very satisfied. Professional athletes are very driven. I play basketball. I'm very satisfied just running up and down the court. I don't care. It's fine. How about with practice? Well, Michael Jordan his ability to play basketball is quite high. My ability to play basketball is pretty poor, but I'm satisfied with it. They don't have to be the same thing. My point is that you have to, when you're giving surveys like this, explain to people that there are no right or wrong answers. Everybody is in a different place. And you'll get more honest answers if you do that. Okay. Case studies. Do any of you, is there anyone in the audience who has ever had one of their participants in a wellness center do a case study for them? I sent you out a template of what one of these case studies may look like. Um, and I can go over it if anyone wants me to, but you have it. Excuse me. Why would a case study be used? Actually, I found, even when I was doing a lot of writing, when my last book came out, I had a lot of case study vignettes from clients. Clients were actually very grateful of being given the opportunity to tell their story. And we hear that over and over again, that in traditional psychiatric kinds of treatments, they weren't really encouraged to tell their whole story, all the things that happened to them, not just negatively, but where they came from and where they're going and who they are as a person. So actually, clients actually often like doing case studies. Case studies also can be used to highlight or strengthen other data. For example, again, I will emphasize in the small counties, sometimes your data is just frankly not going to look very impressive. But if you have like a one-page case study that was written by a client, that it provides a human element, it provides the story, it provides the context of what happens. It can really strengthen your reports. Also, case studies can also be used more in vignettes, smaller versions, for public relations and outreach. If you're doing presentations, I know a lot of you are involved in stigma-busting movements. Nothing in my mind is more effective than hearing someone's personal story. And either in person, where they tell an audience, some people don't want to do that. You can have very small vignettes on your website. There's all sorts of ways you can use these, but the idea is the real personal stories are what's so meaningful. I had the opportunity a couple of years ago to present at an occupational therapy conference in Sacramento with the 3 peer specialists that I work with. And everybody in OT in California knows me. They were like, oh, yeah, hi. But they were really interested in hearing from them and were just fascinated with hearing their stories and the incredible progress they've made and what their lives are like now and what's important to them. It was a very, very powerful presentation that I'm still hearing about. So case studies can be fabulous for that. There is also a way that you can create a thematic record with multiple case studies and do a little qualitative analysis on that, but I wouldn't necessarily suggest that unless you have someone who really understands qualitative research. So what are the limitations of case studies? They are what's called anecdotal. One person's experience certainly doesn't represent everyone's path to wellness. And you can always say that, these results are just one person, but this represents some things that happen. So they may not be viewed as strong data in the traditional scientific sense, but the strengths is not just for outcomes, although I do think they are important. I think when people with lived experience of mental illness can share their own story, it's very helpful role modeling. It provides a personal connection. It does work well for small populations. It can show us how individual the paths are to recovery and can be used for promotion and marketing. And again, I included a template for doing a case study in your packet, and you know what? I am just going to take a quick look at it again, in case you haven't had a chance to see it. You should have all gotten these. So what I have here is the whole process of how you would go about inviting someone in your center to do one. You invite the participant to share a personal story. It is very important that the individual know this is completely voluntary and that assistance will be provided. Some people really want to tell their story, and they have a fascinating story to tell that would be very helpful for a lot of people to know, other consumers, funders, community members, etc. But they may not be very good at writing it. They may need some help with editing, or they may not be very good at public speaking. They may get very tangential, so they may need a coach. to help them get it into final form. But again, I have found a lot of people really want to do this, and they just may need some help to get them there. So, discussing the benefits of a project like that, both for the organization and the individual, and explaining how it'll be used, be very clear that if they want it, it can be completely anonymous. A lot of people that I've worked with, for those of you who've seen my book or the chapter that I wrote on recovery with the peer specialist, one of the peer specialists from Trinity, obviously in publishing, people get very concerned about releases and all that. Every single person said, no, use my name. I'm not embarrassed. I'm not ashamed. I want to put my name out there. So I was really pleased with that. But some people may want to keep it anonymous, and that is fine. They need to know how this material is going to be used, and you do need a release of information if there's photographs involved or written information of any kind. Again, have them have a partner, a coach of some kind. Edit the document. It really is better if it's not longer than a page. And once the final case study is in good shape, make sure you get final approval from the individual. It is both a legal and ethical right to see the final product, and you usually do need to have a signed form with that. Keep an electronic copy and provide a copy to the individual. I have had many situations where, I edit things for a living. I write a lot. So I do this, I think, a great job editing, and I come back to the person, they go, oh, but you left out this story, or you left out that story. And then we have to renegotiate again and say, okay, but something's got to give because it's too long, so how do we do it? So hopefully you have someone helping them who's good at negotiation. And then I just provided some questions. You may come up with different ones, that's fine. These are only suggestions. But a lot of people, even ones who are bursting to tell their story, don't know where to start sometimes. So having, kind of bullet points. Describe your symptoms or stressors that got you here. In other words, that's the baseline. What services were given into you? That was the interventions. Your relationships, how did this help you with recovery? Emphasizing the positive of the service and relationships. What did you learn about yourself? A very specific event. Again, having concrete stories really helps. I always like to highlight one specific event if you can, because otherwise sometimes it just sounds very vague and kind of mushy. And baseline versus outcome. How do you see yourself now as compared to when you started attending this center, and what are your goals for the future? So you hit the past, present, and future. Any of you have any case studies or shorter vignettes that consumers have given you, or can you see yourself doing something like that at your center? Would it be helpful? Well, again, if you want to talk to me about it at any time, I do think I personally think it's helpful to do that.
And there is a question going back to outcomes.
Okay.
What does the state value for showing outcomes?
That's a very good question. It depends on what you mean by the state. There's different funding streams. If you're talking about MHSA reporting, one thing I really like about the Mental Health Service Act is that they understand that there's a big learning curve involved in wellness and recovery. And what they're going to mainly be looking for is progress, not necessarily the world is perfect and everybody's healthy. So documenting progress. So that's where the baseline stuff becomes so important. If you can say there has been a change from here to here, that's going to be great. I'm going to back up way back. These measures of individual recovery, one of the reasons I included this slide is this comes from research. This comes from a study. So if you're writing for someone a report for funding, say to the state of California, and you did some groups about daily living skills, and you had some pre and post kind of outcomes that people got better about independent living skills, shopping, money management. I'm just using this as an example. You can say right in your report, Campbell Ord et al. In a 2005 study concluded that daily functioning was one of the important measures of individual recovery. The fact that you have a little literature to back that up means that it is important. Some people dismiss it. Oh, great! We took 6 months to teach someone to learn how to use a checkbook. Well, yeah, because this is where their baseline was. It was very low, and now it's much higher. You can use wording like this taken from a study to give it more importance, and the state, as well as any other funding source or oversight source, acknowledges that. Ultimately, now that's the kind of rosy view of it. A more cynical view is money. If the outcomes you have can show that by working with peers in a wellness center, decreased crises, decreased dependency on more expensive services, decreased hospitalization. Oh boy, they love outcomes like that. They're more willing to continue funding things like wellness centers that frankly do not cost as much as intensive professional clinical services, whether it's hospitalization or not. But they need to see that this isn't just a nice, friendly thing they're doing, that in fact there is some monetary advantages to it. In my mind, but I'm too logical sometimes, this just makes common sense. If people are feeling healthier and feeling safe and feeling that they belong in a community, they're not going to have as many crises. If they have people who can help them before they get to the point of completely falling apart, in this prevention mode, to me it's just kind of common sense or logical that it's going to save money. But funding sources don't always see that because prevention is very hard to measure. So you kind of have to spell it out for them. And even in a case study, even though that's just one person, if someone has this history, and I remember one case in particular that I helped someone write up, where before they were involved in a wellness center, and before they got their confidence and hope back, and before they were learned some symptoms, they were hospitalized 2 or 3 times a year. And the end result of this case study is this particular woman hadn't been hospitalized in 3 years. That's huge. That is huge. Even though it's just one person, it represents what this kind of wellness-focused, recovery-focused, prevention-focused services can do. That answer your question? Okay, any other questions?
There is one comment that says that we do vignettes every 3 months.
Fabulous. Oh, do you, I'm curious, do you have what do you do with them? Do you just collect them and then write them up later on, or do you have a website that you post them on, or are they posted around the center? What do you do with them? I didn't mean to put you on the spot there, but again, think through, it's great that you collect them, but think through what's the next step. Well, what will these vignettes show? It may be that because you don't have releases of information or whatever, you don't want to make them public, but at some point you probably need to examine them, come up with themes, write up a summary of what kind of changes you're seeing. Again, the whole point of outcomes is you need to know where you start and you need to know where you end and have some kind of narrative or measurement as to what changed. That's really the key.
He says we send them into the county as part of our data collection.
Okay, great. The counties, depending on well, the counties vary a lot, but they do want it. They are the conduit for funding. Well, even if ultimately your funding comes from the state or even the federal government, it's usually channeled through the county, and they need to. They want some kind of report, and different boards of supervisors vary in how much detail they want. But that sounds great. Makes perfect sense to me.
He says they
Okay.
show the faces of real people and their stories to show progress.
Exactly. Key word there, showing progress. Um, it does two different things. The showing the progress part, frankly, will allow you to keep open and keep funded and keep supported because that's what it's really all about. But you're doing it in a way that shows the humanity. And I personally can think of no other better stigma-busting process than showing people as people. As complicated and deep people. I love it. Thank you. Okay. Um, two more things here. Archival and demographic records. This gets to the point I was saying earlier. Almost everybody has to collect this at some point. This is the numbers. And it may or may not be need a accompanying resume. For example, the kind of numbers you may collect is the number of visits, the population per day, the groups offered, the number of specific services. For example, if you offer case management or some other kind of one-to-one intervention, the frequency and duration of services, the closure of records, the completion of records, etc. I strongly urge that whoever is responsible for collecting the archival data have up-to-date computer skills, at the very minimum knowledge of using Excel and Microsoft Word, and just what are the processes for keeping good records is critical. Okay. And the last one that I have there is external reviews. This one, you may want to report to your county or state or funding source, but it's also just kind of a way to make sure that you're staying on track. It can be done informally or formally, in other words. I think it's very beneficial to have an outsider come in and evaluate your program. They're more objective. They don't know the politics of the place. They don't know the relationships. They don't know the conflicts that occur in all work settings. But they can often, because of that, they can often see solutions that may not be apparent to you in the workplace. And just as importantly, a good external evaluator can identify behaviors and attitudes that may stand in the way of organizational change. And there are many people who volunteer to do these kind of external reviews. I mean, I've done them both volunteer and paid because I consult for a lot of different kinds of places. But it's really helpful to just have fresh eyes. In other words, it's much more objective. And that report, if you ask your evaluator, your external reviewer, to write up a simple report, can be used as a part of your reporting. Okay? So, what are your plans? Do you have plans or ideas for your own data collection? Was there one takeaway point from this that you could see yourself trying, and what help do you need in order to do that? Okay, sounds like you need to think about this a little more. Again, I am more than willing to take your email at any time. And I will respond to you if after you've had a chance to. One problem with teaching in short bursts like this, 90 minutes, is that it doesn't give people a chance to let things sink in and reflect on it and think about it. That's why I always keep offering. A question may come to you tomorrow. Feel free to email it to me. I'm fine with that. Okay, last slide. Again, any resources you didn't get, Shoshana can get them to you, or if, some of them Shoshana doesn't have. The templates that I showed you that I didn't send ahead of time, that's my email. Again, feel free to write to me at any time. I'll send you more resources or answer any questions. Our next webinar is called Skills for Advocacy and Leadership, and I'm very happy to say I'm going to have a co-presenter, Ron Shaw, who is the program specialist from NAMI for Central Region, is going to co-present with me. He's done a lot of work on this, and that will be January 8th, 10 to 11:30. I have one more plea to send out. Would really like, this is my, I can't remember if it's my third or fourth year. I think it's my third year of doing these webinars. As much as I love doing them, and I'm very grateful to CIMH for inviting me back every year, I really would like to work on a system of getting more people involved in doing them, particularly peer specialists or peers or consumers. So I'm throwing out an offer. If you think you might want to do something like this, but don't feel you have the skill or are a little shy or don't really know if you can do it, I'm happy to work with you. You don't have to do it all by yourself, but please write to me. For those of you who were involved last year, you may remember on our survey that we sent out, we asked for topic ideas and if you wanted to do any of them. I wrote back to a lot of people. I may have lost some of the material. I'm not sure. If I missed you, I apologize. But I did write back to people asking if they wanted to present. Didn't get a lot of feedback. So again, I'm going to ask you to think about it again. Anyone who would like to present a particular topic or work with me on presenting one, I would really like to hear from you. Otherwise, I've got plenty to talk about. And, you know, I could talk from here to Kingdom Comes. So if I don't hear from people or if we don't come up with other presenters by the next session, January 8th, I will be, I have plenty of other topics based on your feedback, by the way. It's not just all my ideas, for the remaining webinars for the rest of the year. So before we close, one last chance. Any comments or questions?
Thank you for the email option.
Sure. I'm more than happy to do it.
A smile is a good indicator of a successful outcome.
Absolutely.
To document pictures or use pictures.
Yes, yes, absolutely. Thank you. And again, a lot of those scales just have very simple smiley faces and grimace faces. That's fine. I tend to like to use clip art, but that's just me. Okay, we finished a little early, but if there aren't any other comments, I think that's fine. I covered what I wanted to cover, and I hope you found it useful. And I hope you'll join us again on Wednesday, January 8th, to hear what Ron Shaw has to say about skills for advocacy and leadership. Again, thank you very much.
Thank you, Anne.
All right. Take care.
Bye, everyone.
Bye, everybody.